The topic of today's discussion is fluid and electrolytes, and I'm Dr. Shenal Thalgahagoda, consultant pediatric nephrologist at Teaching Hospital Pennsylvania. So during the course of this lecture, just to give you an overview, we'll be dealing with the normal requirements, then we'll be touching on the types of fluids available in hospital. I'll be touching on how to assess dehydration, and we'll follow that with the management of dehydration. And finally we'll end with how to manage sodium imbalance as well as potassium imbalance, which are the two main electrolyte imbalances we encounter in clinical practice. So what are the normal requirements of a child in the first 24 hours? First, let's deal with fluid, water. So the fluid requirements are basically calculated according to what is called the holiday formula, where we give 100 ml per kg for the first 10 kilograms, followed by 50 ml per kg for the second 10 kilograms, that's from 10 to 20, and for every subsequent kilogram we add 20 ml per kg. We'll move on to an example to make this clearer. And as you see, with sodium, potassium, energy and protein as well, the requirement is higher with in the first 10 kilograms. Say for instance for sodium it's 2 to 4 millimoles per kg, for the second 10 kilograms it's 1 to 2, and for every subsequent kilogram that is above 20 kilograms it's 0.5 to 1. And a similar pattern is seen when dealing with energy and proteins as well. So what are the types of fluids available in the wards? A lot of you would have worked in wards, in pediatric wards as well. So we have crystalloids in the form of normal saline and half normal saline. Remember, the world is moving more towards using isotonic solutions, which namely are normal saline and Hartmann solution, as well as renal lactates, and the use of half normal saline and N/5 saline are moving out. You hardly ever find N/5 saline on the wards these days. So it's we mainly deal with normal saline and Hartmann solution. We also have 5% dextrose and 10% dextrose to adjust the sugar requirement. Colloids are found in the form of dextran and hetastarch. We also have human albumin as well as some of the blood products which can be used as colloids. Moving on to the constituents of crystalloids, you see normal saline has only sodium and chloride. So you get 154 millimoles per liter each of sodium and chloride. Half normal is basically roughly half that, or basically is half that, but you do get a little bit of dextrose in half normal saline as well. N/5 is basically half that, there is 1/5 that rather, and again you get dextrose in N/5. Hartmann solution and renal lactate are very similar, though not identical, and both these solutions contain a lower lower concentration rather of sodium, but they do also contain some amount of potassium and bicarbonate as well as a bit of calcium. The two solutions can be used depending on which is available, and they're very similar. In constitution. So let's move on to dehydration, and let's first deal with the clinical features, because assessment of the fluid status when managing a child with dehydration is of extreme importance. The amount of fluid you're going to give will depend on the status or the degree of dehydration that the child presents with. So if you assess the degree of dehydration, or your assessment is wrong, remember the volume of fluid you will give will also be miscalculated and it will be wrong. So a thorough assessment is necessary with regards to the degree of dehydration. So mild we categorize dehydration as mild, moderate and severe. Mild dehydration is when there is less than 5% dehydration. These children basically will present with very minimal signs and symptoms. They may be a little bit thirsty, and a little bit of thirst may be the only symptom they present with. Moderate as opposed to severe dehydration, where the child presents with very major symptoms. They may be lethargic, they may even be unconscious and floppy. Extremities will be cold and clammy. There will be evidence of circulatory failure with tachycardia, prolonged capillary refilling time, and low blood pressure. They may be unable to drink, and they may show signs of severe dehydration with absent urine output and a very low skin retraction when it comes to checking skin turgor. Moderate dehydration is somewhere in between the two. So remember, again, the assessment of dehydration is extremely important, because the amount of fluid you're going to give this patient will depend on the degree of dehydration. Let's move on to management. Firstly, we'll deal with severe dehydration, and subsequently we'll touch on moderate dehydration. Now, severe dehydration is when the degree of dehydration is more than 10%, and these children may also be in shock. So if the patient is in shock, you need to replenish the circulation first. So you need to you observe your airway, breathing and circulation maneuvers. The main problem should be in the circulation, though the other parameters also may be impaired. And if the patient is in circulatory failure or in other words in shock, you need to manage that first before you move on to severe dehydration management. So if the shock is managed with 10 to 20 ml per kg boluses, we now prefer to use 10 ml per kg boluses to start with, and this may be given in either normal saline or Hartmann solution. So this should be continued or repeated until the patient's circulation is intact. And that volume of fluid that you give to replenish the circulation as boluses should not be taken into the assessment of severe dehydration, the calculation of severe dehydration management, because the boluses are used to replenish the depleted circulation and not to correct the dehydration. So you need to check the random blood sugar in these patients, because they may be hypoglycemic, and that may be why they may have loss of consciousness or altered consciousness. And if they are tachypneic, you also need to consider build-up of lactic acidosis. So you need to consider acidosis, and you need to assess the renal functions. You need to assess their electrolytes, and as mentioned, you need to do a blood gas as well. And you need to monitor their urine output. Catheterization may be necessary. So urine output, the ideal urine output should be 1 ml per kg per hour, but anything above 0.5 will be acceptable. You need to aim at a high urine output for infants and neonates. So let's move on to the management of severe dehydration. Now there are two methods that are commonly used. One is the World Health Organization or WHO method of severe dehydration management, and the other method is the Apls method of severe dehydration management. I'll deal with both first, and then we'll just compare the two to basically find out which method is more appropriate in clinical practice. So according to the WHO method, in infants and other malnourished children, first you give 30 milliliters per kg 30 milliliters per kg of intravenous fluid over 1 hour, and thereafter you follow it subsequently with 70 ml per kg over 5 hours. So the total volumes, we are calculating 10% dehydration, so that's 100 ml per kg. So out of that, the first 30 ml, or the first 30% of the first 30 ml per kg is given over 1 hour, and the subsequent 70 ml per kg is given over 5 hours. So the total 100 ml per kg deficit correction occurs over 6 hours. That is in infants and malnourished children. If the child is over 1 year and obviously is not malnourished, the first 30 ml per kg of the 100 ml per kg total volume or deficit correction should occur over 30 minutes, and thereafter the subsequent 70 ml per kg should occur over 2.5 hours. So the total duration of correction of the deficit is 3 hours. So your total deficit of 100 ml per kg should be corrected with normal saline or Hartmann solution with added dextrose. Just to give you an example, management of severe dehydration, a 20 kilogram child with severe dehydration, what is the deficit? So we said 100 ml per, we said the deficit is calculated as 10% dehydration is 100 ml per kg. So your deficit is 100 into 20, which is 2000 milliliters. So in the first 30 minutes you give 30 ml per kg or 600 ml, and in the next 2.5 hours you give 70 ml per kg or 1400 ml. So your total volume, the total volume that you are going to give this 20 ml, the 20 kilogram child is 2000 ml over 3 hours. So subsequent to the correction of dehydration, you need to reassess the child's level of dehydration. If he's still dehydrated, correct that dehydration accordingly, and you need to continue maintenance, as well as you need to replace the ongoing losses as well. Let's move on to the Apls method. This method is a little more complicated than the WHO method, but for reasons which I will be dealing with in a little while, this method is much more accurate and appropriate for clinical practice. So according to the Apls method, within the first 8 hours of a 24-hour period, you correct half the deficit plus 1/3 of the maintenance. So in the first 8 hours you correct half the deficit as well as 1/3 of the maintenance. I'll give you an example to clarify this, and in the next 16 hours you correct the other half of the deficit as well as 2/3 of the as well as the subsequent 2/3 of the maintenance. So in essence, what you're really doing is giving half the deficit over the first 8 hours, and the subsequent other half of the subsequent second half of the deficit is corrected over the next over the subsequent 16 hours. Maintenance is basically given equally over a 24-hour period, right? So deficit is 100 ml per kg, normal saline or Hartmann's, maintenance normal saline. This method is better than the Apls method because it gives you a more gradual correction of the dehydration. So let's move on to electrolyte imbalances. So we are going to deal with, as I mentioned in the overview, we're going to deal with hypernatremia, then hyponatremia or the sodium imbalances, and subsequent to that we're going to deal with potassium imbalances in the form of hypo and hypokalemia. So what is hypernatremia? Hypernatremia is when your serum sodium level is over 150 millimoles per kg. The normal sodium value, as you all know, is 135 to 145 millimoles per liter. When it goes over 150, we consider it as clinically relevant hyponatremia. So what are the causes of hypernatremia? So hypernatremia can occur when the loss of water is in excess of the loss of sodium. So you can be losing both water and sodium, but the loss of water is in excess of the loss of sodium. So this can happen with GI losses, with phototherapy, burns, and sometimes even with dehydration due to that occurs on the sports field with heat stroke and so on. So here the water loss is in excess of the sodium loss. The second cause of hypernatremia is when there is inadequate water intake, or when there is excessive renal water loss. So again, their water intake is either low, or your renal water losses are low, where the sodium remains static to a certain extent. So this can occur with lactation failure, with starvation, and renal water loss occurs with the condition known as diabetes insipidus, which is basically the inability of the kidneys to respond to antidiuretic hormones. So these patients present with severe polyuria, and they cannot basically concentrate their urine. So these patients have quite severe and recurrent hypernatremia. Hyponatremia also occurs when there is a gain of sodium in excess of water, and this can occur with salt poisoning or intentional salt poisoning. It can be iatrogenic sometimes when you use persistently fluids with a high sodium intake. It's common when patients are on formula feeds, when the milk is prepared inappropriately, you use an overconcentrated formula, which is again rich in sodium. Those babies are likely to develop hypernatremia. And also, aldosterone leads to sodium retention. So when there is an excess of mineralocorticoids, as in Conn syndrome, the patients can develop hypernatremia. So here in the last example, there is a gain of sodium in excess of water. So let's deal with hyponatremic dehydration and the clinical features. So these patients usually present with CNS dysfunction, and they can have lethargy, irritability, neck stiffness, seizures, drowsiness, coma, and they can even present with intracranial hemorrhage. So if you just look at the features, the clinical features, they're very similar to those of meningitis, and they really mimic a child with meningitis. They're irritable, have neck stiffness, they can be drowsy, right? So it's very, very similar to the clinical features of meningitis. And another important point with regard to hyponatremic dehydration is that the signs of dehydration may be masked quite significantly. This is because there's a shift of fluid from the intracellular to the extracellular fluid, which is hypernatremic, and because the extracellular fluid, because of this fluid shift, the patients do not manifest the signs of dehydration. So they can really look quite well hydrated, despite being actually severely dehydrated. So just before we deal with the management of hyponatremic dehydration, a little bit of physiology is necessary to understand as to why we do the things we do. So when a patient is hypernatremic, your extracellular osmolality is higher than the intracellular osmolality. So because of this, as an adaptation, the intracellular compartment produces what are known as low molecular weight organic compounds, which basically prevent the, so because if the osmolality in the intracellular compartment is lower than the extracellular compartment, there is a tendency for fluid to shift from the intracellular to the extracellular compartment. To counter this, the intracellular compartment produces these low molecular weight organic molecules which raise the intracellular osmolality and thus prevent the fluid from shifting from the intracellular to the extracellular compartment. Now this happens over a period of time. So if you correct the extracellular hypernatremia rapidly, what happens is that the extracellular osmolality drops remarkably and very rapidly, and this leads to a shift of fluid from the extracellular compartment, which is now hypoosmolar or has a lower osmolality. There's a shift of fluid from the extracellular compartment to the intracellular compartment, and if this occurs in the central nervous system, the cellular edema can lead to cerebral edema, and the patient can have seizures. Therefore, when you correct hypernatremia, the drop in sodium should be very, very gradual, and this is of utmost importance to consider. So the rate of sodium reduction should be less than 12 millimoles per liter over a 24-hour period, or less than 0.5 millimoles per liter per hour. This is extremely important. So what you do is you calculate the deficit and maintenance for 48 hours, and you replace the fluid depending on the duration of correction. Would depend on the duration of correction would depend on the degree of hypernatremia. So if your sodium is between 145 and 157 millimoles per liter, you can correct the deficit over 24 hours. So obviously your maintenance here is going to be calculated for 24 hours, and the deficit also can be corrected over 24 hours. So you can have a relatively rapid correction because your hyponatremia is not that severe. So here you'd calculate your maintenance for 24 hours with the deficit, and that total volume you'd correct it over 24 hours. If your sodium is between 158 and 170 millimoles per liter, so if you really look at it, you're going up in 12 millimoles per liter aliquots, right? So if it is between 158 and 170, you correct the deficit plus the maintenance. Your fluid volume is the deficit plus maintenance, and you correct it over 48 hours. Right? So basically the deficit correction goes over 48 hours. Maintenance has to be calculated for 48 hours. If your sodium is between 171 and 183, or the next 12 millimole per liter aliquot, you correct it over 72 hours. If it is very severe, from 184 to 96, you correct it over 84 hours. Right. So what is the type of fluid you're going to use? This can be either normal saline or half normal saline. But whatever fluid you do choose to use, you need to monitor your electrolytes. And if you're using normal saline, and the sodium is dropping too slowly, you can switch to half normal saline. If you're using half normal saline and the sodium is dropping too fast, you switch to normal saline. Sometimes you might even have to use half the volume in normal saline, half the volume in half normal saline, and you need to make your fluid adjustment according to the drop in sodium. What is hyponatremia? By definition, this is when the serum sodium is below 30 millimoles per liter, and basically there are two causes. When there is a loss of sodium in excess of water, as occurs with GI losses, as with diuretics in certain tubulopathies, which you will deal with, which we will learn when you are seeing patients in clinical practice. So usually in GI losses or with diuretics, the kidney in diuretics, your sodium loss is in excess of your fluid loss. There can also be gain of water in excess of sodium. This occurs very commonly when you use when you pretend to use half normal saline or low sodium intravenous fluids. Some children are compulsive water drinkers, so they consume a lot of water, which is hypo, which obviously does not contain sodium. The syndrome of inappropriate ADH secretion is where, because of the action of antidiuretic hormone, the kidney tends to retain more water, and this basically dilutes the intracellular, dilutes the serum sodium. And in cardiac failure as well, due to mainly the action of atrial natriuretic peptide, your kidneys tend to excrete more sodium, and that causes hyponatremia. So these children can present in numerous ways. They may be edematous without hypovolemia. They may be edematous with hypovolemia. They can be hypovolemic without edema, and they can be normovolemic. So normovolemic patients with SIADH, these patients are normovolemic. Patients can be edematous without hypovolemia. Example would be heart failure, right? They can be edematous with hypovolemia, as occurs in patients with nephrotic syndrome because of the action of because of activation of the renin-angiotensin aldosterone axis and also antidiuretic hormone. You can have water retention, oversalt retention, and they can be edematous but hypovolemic, and they can also be hypovolemic without edema in patients with diarrhea and dehydration. How do you manage patients with syndrome of inappropriate ADH secretion? You need to restrict the fluids. Usually you restrict to 50% of maintenance, and if there are severe neurological symptoms, or if the sodium is below 120, you need to correct the serum sodium to above 125 millimoles per liter. For this, you can use 3% saline, which has a sodium concentration of roughly 530 millimoles per liter, or 0.5 millimoles, or roughly 0.5 millimoles per ml. So the formula to correct sodium deficit, or to calculate the sodium deficit, is 0.6 into kilogram body weight into the deficit. So we'll just take an example of a 10 kilogram baby with a serum sodium of 115 millimoles per liter, who also presents with seizures. So you need to correct the serum sodium rapidly, at least up to 125. So sodium requirement is 0.6 into 10 kilos, into the deficit, which is 125 minus 115. So basically the requirement is for 60 millimoles per liter. So if you're correcting with 3% saline, 3% saline contains 0.5 millimoles per liter, so your volume is 120 ml of 3% saline, and this should be corrected over a period of about 3 hours. Let's move on to potassium and hyperkalemia, which is a very dangerous electrolyte anomaly. This is defined as a serum potassium of more than 6 millimoles per liter. In infants tolerate hyperkalemia a little better, so the serum sodium can be even, you'd watch up to even 6.5 millimoles per liter. Right? So what are the causes of hyperkalemia? Mainly these are due to problems with the kidneys or due to kidney failure. So if the GFR is below 15 millimoles, 15 ml per minute per 1.73 meters squared, if patient's acute renal failure or in end-stage renal failure due to chronic renal failure, these patients can be hyperkalemic. And in patients with obstructive uropathy, hyperkalemia can occur even earlier. Right? Also, the action of aldosterone leads to retention of sodium and water, as well as to excretion of potassium. So when there is deficiency of aldosterone, you get excretion of sodium and retention of sodium. So a few conditions that have aldosterone deficiency are congenital adrenal hyperplasia, which you will see when you come to clinical practice, and obviously Addison's disease. Certain drugs like ACE inhibitors and angiotensin receptor blockers also, due to blockage of aldosterone, lead to aldosterone deficiency and hyperkalemia. What are the clinical features of hyperkalemia? These patients can present with severe muscle weakness. They can even present with with paralysis. I've seen patients who were thought to have even Guillain-Barré syndrome because they presented with acute flaccidity, but they're found to be hyperkalemic due to renal failure. And the other major killer is the cardiac arrhythmias caused by hyperkalemia. So the ECG changes of hyperkalemia are extremely important. Firstly, you get peaked or tented D waves, then you get the D waves, then you get the loss of the P wave, widening of the QRS complex, ST depression, with subsequent bradycardia, heart block, ventricular arrhythmias, and finally cardiac arrest. So how do you manage hyperkalemia? If it is a chronic hyperkalemia, dietary restriction is important, and even in acute hyperkalemia, you should prevent the patient from taking any more potassium on board. So you restrict, so the dietary restriction of potassium is important. Acutely, you can nebulize the patient with salbutamol, because salbutamol serves to drive the potassium from the extracellular compartment to the intracellular compartment, and that thereby protect the heart from the effects of hyperkalemia. You can use what is called sodium polystyrene resin, which is given orally and prevents further absorption of potassium from the gut into the circulation. Calcium gluconate, a bolus of calcium gluconate will help to stabilize the cardiac muscle and make it less responsive to the effects of hyperkalemia. You can use sodium bicarbonate because when you reduce, bicarbonate also serves to drive potassium into the intracellular, serves to drive potassium into the intracellular compartment. Insulin is also used again basically to drive sodium from the intracellular compartment, from the extracellular compartment into the intracellular compartment. So all these methods basically are basically just buying time. You're not reducing the body potassium content. You're just preventing any addition of potassium into the body, and you're driving the extracellular potassium into the intracellular compartment to prevent the toxic effects of hyperkalemia. So ultimately, if the patient remains hyperkalemic, you need to dialyze them to get rid of the potassium. What about hypokalemia? This is defined as a serum potassium less than 3.4 or 3.5 millimoles per liter. Causes are inadequate provision due to use of IV fluids, which usually say normal saline, half normal saline. They do not contain any potassium, so if you do not add potassium to it, or you do not use Hartmann or renal lactate solution, you're not giving the patient any potassium, and if he's not taking anything orally, he's going to get hypokalemic eventually. Intestinal losses in the form of diarrhea and vomiting also can lead to potassium loss, and you can have renal losses of potassium in certain conditions like Bartter syndrome and renal tubular acidosis. And there can also be a shift of potassium from the extracellular fluid to the intracellular fluid. We mentioned salbutamol, which is used as a therapeutic agent for hyperkalemia. When you use it in asthma, those patients tend to become hypokalemic. What are the clinical features of hypokalemia? There can be lethargy and confusion. There can be muscle weakness and paralysis, as with hyperkalemia, right? And there can be smooth muscle involvement. So you can have smooth muscle paralysis, and this can lead to paralytic ileus. So these patients can present with basically can be present with intestinal obstruction, not due to paralysis of the gut. And they can also lead to urethric dilatation. Sometimes persistent hypokalemia can lead to urethric dilatation due to smooth muscle relaxation. You can have cardiac ischemia and cardiac arrhythmias due to hypokalemia, and prolonged or long-standing hypokalemia can lead to muscle necrosis and myoglobinuria due to rhabdomyolysis. And remember that long-term hypokalemia is nephrotoxic, and it also reduces the kidney's concentrating ability. What are the Ecg features of hypokalemia? So you can get an increased U wave amplitude, again prolonged QRS complexes, ST depression, reduced T wave amplitude, increased P wave amplitude, and subsequently a prolonged period and also prolonged PR interval. How do you manage hypokalemia? Again, you need to acutely correct it. So 0.6 millimoles per the equation again is similar, 0.6 into body weight into deficit. You correct it up to 3.5 or 4 sometimes. Chronic hypokalemia, you can correct it with oral supplementation. I think that's the end of this lecture. Hope it was helpful.